Now, please welcome your host for today's webinar, Marlise Perez.
Great. Well, welcome everybody. I can see we still have some folks joining us, but as they're joining, we can just move to the next slide. And just want to go over a few housekeeping items for the day. So as was already mentioned, the event is being recorded. And then if you're having any speaker issues or things like that, you can put in the Q&A and tech support will reach out to you as well. And live captioning is available. So in order to access that, just click the CC live transcription button. And then if we move to the next slide, just want to remind everyone that, really encourage your participation today. You can place your comments, and we really want to hear your feedback. That's what today is all about in the Q&A. So please put in as much as you can feedback there, and then also we'll be accepting feedback over the next few days. I'm going to move to the next slide. If you think later on or over the next few days, there's other things that kind of come to mind on some of the topics we're going to be discussing today, you're welcome to provide us with written feedback as well. So for the format today, what's going to happen is I'm going to present some general information for you about the County Integrated Plan for Behavioral Health Services and Outcomes. And then I have about 5 questions, so we're going to stop for each one to receive your feedback, and then we'll move on to the next question. All right, next slide, please. So as I mentioned, you can provide feedback through the Q&A box here on your panel, or you can send an email, and this is the email address here, the bhtinfo@dhcs.ca.gov. So we are asking for your feedback by June 7th. That is just so we can put together a summary document. Just to be clear, if you send us feedback on June 8th or July 8th or whenever you do, we are still welcoming that. It just won't be included in the summary document, but we will be still reviewing that at DHCS. All right, next slide. So hi, for those of you I haven't had the chance to meet, I'm Marlise Perez. I'm the Chief of our Community Services Division at DHCS. So thank you so much for joining us today. Really value your time, whether you're online live with us right now or viewing the recording. Next slide. So what we're here to talk about is the behavioral health transformation, also known as Proposition 1. And so as most of you already know, Proposition 1 was passed in March of this year. It was a 2-package bill that ran through the legislature. One piece of the legislation resulted in the Behavioral Health Services Act. And really what that act does is it really reforms the efforts around the Mental Health Services Act. And this is really to expand services, especially for a new population around individuals that only have a substance use disorder. And then, of course, there's a lot of other changes to the BHSA as well around the services, how the funding is spent. It also expands the workforce and has a really large focus on outcomes, accountability, and equity. And then we also have the Behavioral Health Infrastructure Bond Act. It's a second piece of legislation, and this really is to bricks and mortar build housing under our for behavioral health individuals that have conditions, but also under our BCHIP, our Behavioral Health Continuum Infrastructure Program, a little over $4 billion to construct treatment facilities. So we're not going to be talking about the Bond Act today. I would encourage you, if you want to go back and see, we had our listening session last month about the BCHIP portion of the Bond Act. Feel free to go back and review either that recording or the slide deck or the summary document is there. But what we are going to focus on today is a portion of the Behavioral Health Services Act. So we'll get into that in just a moment. Next slide. So as I mentioned, with BHSA, the funding breakdown has shifted. You'll see here under the county allocations, there's a new bucket for housing interventions. This is 30%. There's also a new bucket around full service partnership programs. Now that is allowable activity now under MHSA, but it's expanded out. And once again, to also include substance use disorders, that's 35%. And then the third bucket is behavioral health services and supports, which is 35%. We are going to just really wanted to briefly touch on these allocations because this is information that counties are going to be submitting to us in the county integrated plan, which will have more details on that. There's, of course, 10% also for statewide investments. There is state administration, not only for DHCS, but for any of the entities that are participating and have administrative costs. There's 3% for workforce that's being overseen by our partners at HCI, and then 4% in population-based prevention, which is overseen by our partners at California Department of Public Health. We won't be getting into any of these pieces today, but just wanted to make sure to cover that briefly. Next slide. All right, so before we jump too far in, just really wanted to give you a gauge of where we're at right now at DHCS with our initial implementation efforts. So we have begun our stakeholder engagement activities, which are going to continue over the next several years as we have a lot to lift up in relation to behavioral health transformation. As I already mentioned, there are public listening sessions that we're hosting, which you're attending today. We'll host these on a monthly basis with various topics around this transition. And then starting this summer, we are going to have our portion, the $4.4 billion for our behavioral health continuum infrastructure program, our request for application. That's going to be released this summer. If you haven't seen it already, we have released guidance over all of the $4.4 billion that is posted on our website. I'd encourage you to look at that because that really is going to help folks determine if they are interested in applying for that grant funding. And then starting early in 2025, we're going to be releasing the policy needed for our county partners to start planning out their integrated plan. And so that's going to come out in phases. Our first phase of policy guidance will be focused on the integrated plan, but then we'll have other policy that will be released over the next few years, depending on, where we're at in the sense of, so there'll be like guidance around monitoring. Well, that's not needed right up front, but that'll be coming on later on. So with that, this is all in an effort to help our county partners submit their integrated plan. The first year that they need to submit that is 2026. So we do have some time. It's 2 years away though. So I want to recognize there's a lot that we need to do, all of us together, to get this guidance set. So then at the local level, you all can meet together and plan out this funding for your needs locally. Next slide. All right, so just want to talk a little bit about this transition to the integrated plan. Next slide. So right now with the Mental Health Services Act, hopefully most of you already know, there is a 3-year program and expenditure plan that all of our counties have to currently submit. There's also an annual update process, recognizing that, things can shift during the year, different priorities may emerge. And then our counties also provide an annual revenue and expenditures report. And this is once again all geared just toward the MHSA funding. I do just want to note this stays in place until the first integrated plan is due to DHCS. So what is changing with the Behavioral Health Services Act? Now there's a 3-year integrated plan that is provided to DHCS. There are still annual updates. That is still a part of the process. And now there's a new behavioral health outcomes, accountability, and transparency report that we lovingly call the BODER. We are not going to be talking about the BODER today. That will be a different listening session that we focus on, but I did just want to mention it today because it really is a mirror to the integrated plan. Our county partners will tell us how they're going to be planning their money, and then through the BODER, how they have expended their funding. Next slide. So for this integrated plan, just really want to talk a little bit about, the whole purpose of the integrated plan is, once again, it's a prospective plan and also a budget for all of the county behavioral health services. The goal that is outlined in legislation is to have standardized data that's collected and reported to increase transparency at the local level, but also statewide. really encouraging continued and even enhanced stakeholder engagement, and really with the ultimate goal to improve local outcomes and ultimately to really improve services for those individuals with a behavioral health condition. So as I mentioned, it's developed every 3 years, and the first one is due June 30th of 2026. You'll see here on a lot of our slides as well are the citations to the language in case you want to go and read a little bit more about that later. Next slide. So the expanded focus of the integrated plan is really not only to collect local data, but also aggregated data across the state for all behavioral health services that are delivered by counties. This is once again, as I mentioned, to increase transparency and accountability, not only for our county partners, but also at the state level. So we're able to show out what our county partners are doing, but also really to have this data so counties can see what other counties are doing, what other services are being provided, so everyone can learn from each other, but also so they can see what gaps are in their own service delivery system. Next slide. So really we view there's many goals for this integrated plan, but first starting for our counties is really helping them understand their capacity at the local level. This is capacity around what type of providers do they currently have. Once again, maybe additional providers they may need. It's also really to support that community planning process across the various funding streams. Make sure that that is integrated across the funding. Also to really help with the counties, to really be considering the strategies. There's data requirements to look once again at that local need, but also to be able to leverage the county reporting and monitoring. And then for our stakeholder partners outside of the counties, the really big goal around the integrated plan is to make sure that we have the transparency for the counties, that they're moving towards their goals or maybe adjusting their goals once again, just because of changes at the local level or a new epidemic or whatever the case may be. But also that there's transparency in how counties are allocating their funding across the various streams, and an opportunity for stakeholders to provide feedback on those local priorities. Next slide. All right, so just want to jump in on the elements of the integrated plan. Next slide. So you'll see here, apologize for how much is on these slides here, but really just wanted to map out, and I'm not going to go into every single area here today. These will be available and you can do a more in-depth analysis, but just wanted to show you what is required now under MHSA and then what is required under BHSA. So I want to highlight around stakeholder engagement. With BHSA, once again, as I already mentioned, this funding can now be used for individuals that have a substance use disorder, but not also a mental health condition. Right now, MHSA can be used for mental health and co-occurring. So this expands the individuals that will be able to utilize this funding. It also has expansion around key areas of workforce and then also health equity. There is still the public comment reporting, which stays the same. It's 30 days of public comment. There's also still the Board of Supervisors resolution as well. Next slide. There's also, as we have now with MHSA, around county demographics and behavioral health needs, but once again, this has been expanded out really to include unmet behavioral health needs and disparities, really important focus there. Also collaboration with our managed care plans and local health jurisdictions. With the plan goals and performance reporting, there is also counties are going to have to demonstrate how they have alignment with state and local goals. And then for the service and expenditure plan, where this is different under BHSA, is it's not just the BHSA funding that will be reported to DHCS, but it's also all local, state, and federally funded behavioral health services, which also includes the continuum of care capacity and a budget. Next slide. As I mentioned, there's expanded around workforce and personnel. Under BHSA, there's a new requirement around having a strategy to ensure that the behavioral health workforce is robust, well supported, and culturally and linguistically concordant. And I just want to stop quickly for any of our behavioral health workforce listening today. Thank you so much for the work you do. And we're really excited to see how BHSA can support you in continuing this work. So thank you so much. And then also there is still the prudent reserve and the local certification in the BHSA. Next slide. All right, so as I already mentioned, the BHSA requires with the integrated plan to report all of these funding sources here. As I mentioned, these are state, federal, all behavioral health funding sources that the counties currently receive. Next slide. And then really what we are looking at from DHCS is we also want to be able to answer some macro questions through the integrated plan. So as was mentioned, really how are counties spending their behavioral health dollars across their various areas of funding? And I do just want to recognize that there are different requirements for each funding sources. So I think it's going to be really important, and we've already committed at DHCS to make sure that we provide educational materials for our stakeholders to really understand that in some funding sources, counties can only expend it on either certain populations or certain services. So we'll want to make sure that that's clear as well. But also we want to have, to what extent are counties utilizing their funding across the different needs that they have at the local level, which is often referred to as braiding or blending the funds. Because once again, not all funding sources can be used for everything that an individual may need. And then another big macro question that we really want to see addressed is what are the existing disparities and or gaps in behavioral health services that counties are seeking to address? So this could be around special populations, or for special populations, do they have access to the services that they need? And what is the data telling them? And how are they addressing that need? And then what kind of local impact are these services having? So this is really around key outcome measures across counties statewide. We'll be presenting another listening session around performance measures and outcomes, which is a requirement around BHSA as well. And then once again, really looking at the behavioral health workforce. Are there enough individuals? Are they culturally and linguistically concordant? And then how are these investments addressing the local workforce needs? Next slide. So we're going to pop right now into our first feedback question. So this is a time for you all to get in the Q&A there and answer this question for us. Do the macro questions capture the key areas to address through the integrated plan? Would you add or change any? So I'm just going to ask Emma if you wouldn't mind going back to that last slide so folks can see those macro questions that we're proposing right now. And just so the question is, once again, do these resonate with you? Are there any that you would add? And what are you hoping to see? So with that, I am going to turn it over to Tracy, and she is going to start going through and reviewing and reading out some of your responses.
We seem to be getting a lot of questions about many details rather than the actual questions we're asking. Some folks have asked if the slide deck is going to be available, and yes, it will be after this presentation. If you go to the DHCS webpage and you type in behavioral health transformation, we have a page there that is specifically for Proposition 1 or behavioral health transformations, and we post presentations and upcoming listening sessions. And there's also information on how to reach our BHT info mailbox if you have additional feedback. We have some comments here regarding disparities and gaps need to reflect both access and outcomes. Additionally, need to include examining how BH has offset dollars by keeping folks in medical emergency departments while awaiting acute psych hospitalization. Had a question about where do we want feedback. So not in the chat, but in your Q&A area, there should be a button at the bottom of your screen. Someone else suggested that we include questions about addressing local barriers in service delivery. Some
Also
other
seeing, Tracy, what types of services are counties investing in? Are these programs specific to marginalized communities, identities, or age groups?
Another individual said DHCS should consider asking what other networks within the county that the behavioral health department is working with. For example, Aging Services Network or area agencies on aging. That's a tongue twister.
There's also, for the macro questions, please have them separate response to spending on behavioral health by funding source and by age group. I do want to state, I've seen a few comments in here as well, that the integrated plan, the requirement in the legislation is that counties report the funding that they receive for behavioral health services. So all those different areas are outlined, and it sounds like this comment is requesting that DHCS make sure it's broken out by those various sources.
There's another suggestion under local impact to add what are the key conditions or barriers preventing an impact.
Great, and I'm also seeing, I've seen this a few times, but just that sounds like some folks are going to send us comments once you have time to think through the presentation, which completely understand that. They also state that there's, an ever-changing environment in behavioral health. And so they really just sounds like to have an openness that some questions may need to be added as we learn more. And I do want to state, I've seen some themes here as well. That first integrated plan, it covers 3 years, starting with fiscal year 26-27, does 27-28 and 28-29. So that's the coverage period. And so with that, I'm going to move us to the next slide. And once again, we're capturing all of these comments. So if you haven't heard us read yours out loud, it's just we've had so many, which is wonderful. But we go back and review all these as well. So with that, I want to jump into a little bit around the local development process for the integrated plan. And so what you'll see here, as I mentioned earlier, each county is going to need to work with their Medi-Cal managed care plan or plans, depending on how many they have in their county, on the development of the population needs assessment. They also are required to work with the local health jurisdiction on development of the community health improvement plan. So once again, really trying to work and get more integration at that local level. Also, they need to demonstrate that they have a partnership with their local constituents and stakeholders, and just looking at some of that feedback as well. Yes, that includes individuals with lived experience. They are very important and need to have a voice at the table. And also really ensuring that the stakeholder involvement is for around mental health and substance use disorder. And then also just really making sure that it is around all the policy being set, that program planning, health equity, and of course, how they're allocating their budgets. Really wanting to make sure that the stakeholders that are included have diverse viewpoints, really making sure, recognizing each county is different. So this is going to be different depending on the county, but really making sure that we have that broad representation. Also that they need to circulate a draft plan for review and comment to stakeholders. This has to be done for at least 30 days. And then also they need to have an established behavioral health board. The legislation does change. It used to be a mental health board. Now it has to be a behavioral health board. Once again, ensuring that representation from those in the substance use disorder field are represented. And then I just want to note that we are looking at DHCS to see where we have information, where we can pre-populate data for our counties to really help them with this local development process. Next slide. And so, as I mentioned, we have this expanded focus on the integrated plan. You're going to see a lot around data analysis because there's going to be a lot of data that will be provided in this integrated plan. Once again, we're looking to see what do we already collect at DHCS and how can we provide that to our counties so they're not having to duplicate that. We're also really looking around our data to see what can we do to streamline information and really ensure that what we're collecting is really going to assist the counties in putting together their integrated plan. Next slide. So next question is, what guidance or technical assistance from DHCS that we could provide to counties would you like to see regarding the local development process for the integrated plan?
We have one entry regarding support and accountability on equity and addressing disparities. There's also
oh, sorry, Tracy, go right ahead.
There's another suggestion about DHCS providing guidance and TA about how to facilitate meaningful participation by people from groups that are often underserved or experiencing barriers to behavioral health services.
I'm also seeing that lived experience must include care partners or families and really be clearly spelled out.
I'm seeing a couple suggestions about assisting counties with data collection and analysis and gathering data from public and private partners, as well as disability rights and compliance with accommodations. And there's several comments about DHCS making sure that counties are integrating stakeholder feedback into their plans.
Also seeing a lot around how counties like providing TA around gathering data from public and private partners. I'm also getting a lot around like, will there be a template and when will that be available? I do just want to state in one of the earlier slides I mentioned DHCS putting out the guidance in early 2025 for counties to put their plans together. That is what we are talking about, not only the policy, but will also be an integrated plan template. So not only the counties, but all stakeholders will be able to see that. That's what we're gearing toward in 2025. And also we're getting a lot of comments in about certain questions or areas around the integrated plan. These are not responsive to number 2, but that's fine. These are all really great suggestions and feedback. So thank you for those. Tracy?
There's some suggestions also about assisting counties with outreach in underserved LGBTQ communities, as well as BIPOC. Best practices and guidance around housing system coordination to ensure at a local level everyone is working together in a holistic way.
Also seeing one here about providing TA around good examples of a completed integrated plan. Also seeing some TA around the workforce and business processes to keep all providers moving forward long term. Awesome. Well, I'm going to move us. Thank you so much for all of this feedback. And once again, feel free, if you were just thinking and wanted to type some more, feel free to do that. I'm going to move us to the next slide. Oh, great. There we are. Let's see here. So when developing the integrated plan, and really appreciate all the feedback we're receiving today, these are some of our assumptions that we've been thinking about. We really are thinking that the integrated plan needs to be a useful tool for counties to use during the community planning process. We don't want it just to be something that's reported up to the state, but it isn't useful to the county partners and for our local partners as well. Once again, we also are looking to have portions of the plan that is pre-populated with data that is already provided to DHCS, but also ensuring that there's ample places for counties to add their own local data or narrative that needs to be included, that they want to make sure that they can tell their own story as well. We also have the assumption that we want this to be automated. We don't want it to be a paper document anymore. So our assumption around that is we want it to be a web-based platform and a portal where counties can input this information, not only for the integrated plan, but also for the annual update. And then we also want to ensure that there's a uniform format that allows for comparison across the counties. Because one thing I haven't mentioned yet is while we will ensure that each county's integrated plan is posted and available publicly, we're also going to be providing a statewide roll-up of the integrated plans and information in them. So we really want to ensure that there's a uniform format that is, we're comparing the apples to apples. Next slide. So with that, what other assumptions should DHCS take into consideration when we're developing the integrated plan guidance? So what have we missed? Have we hit the mark on some of these, or what else should we consider? And Emma, if you wouldn't mind just popping back to that last slide so folks can kind of see some of the assumptions that we have currently. And with that, I'll turn it on over to Tracy and she can start reading out some of our feedback.
We have a suggestion about the size of the county. It would be nice to have different templates based on size.
Here one, just saying that there are some folks that do ask for paper copies. So maybe there could be some sort of an executive summary or some sort of document that could be printed out that could be provided to folks.
There's some suggestions that the integrated plans be useful tools for those with lived experience and providers.
Also ensuring, and I've seen this as a common theme from different comments, but to ensure that the integrated plan has guidance on the definitions and examples, especially in the new categories. So really making sure it's clear what kind of falls under each bucket.
There are several comments that they concur with the uniformity.
Also seeing a lot of concurrence with the idea of a web-based portal. Also hearing from some of our county partners to really ensure that the counties, with the data they put in, that they can get it back out and use it for their purposes as well.
We also have a couple comments about consumers as well, for them to be able to understand what's in the plan and that it's accessible to them as well in different languages.
A lot of great suggestions around how to organize it. Also, this individual thinks some learning communities could be established by county size and region.
And we have a suggestion for dedicated TA for the web portal.
Also seeing, it's a little more of a question, but it really, I think, links to an assumption of how do we reflect community feedback if the report's automated, but just want to kind of turn that around and just state that it sounds like really making sure that even though it is automated, that it demonstrates where the community feedback is contained. So great suggestion there. Thank you.
We do have a question about, will the data be presented through dashboards or will it be public? And the requirement under BHSA that the integrated plans be transparent and available to the public it still holds.
Right, and just kind of echoing what you said earlier, Tracy, seeing a lot of comments that the plans also include an easy to access resource guide for consumers. I think that's fantastic too. Great, so many wonderful comments and feedback, really appreciate that. I am going to move us to the next slide. And if we could go the next slide after that, Emma, thank you. So as I have been mentioning, the integrated plan is going to have to have counties show how the county has been looking at their local program planning efforts to really maximize opportunities to leverage funding and services from other programs. So that includes our federal funding, which could be through our Medi-Cal entitlement services, also could be through Medi-Cal managed care plans that provide some behavioral health services as well, in addition to commercial health plans. As I mentioned earlier, the integrated plan is going to include a budget template for counties to provide information on all of their behavioral health funding sources. And once again, these are outlined in statute and also their prudent reserve. Next slide. And so, as I mentioned, these are the statutorily required funding sources that must be included in the integrated plan. You'll see here there is some realignment funding, all of our federal dollars that are received through block grants. Those are our Substance Abuse and Mental Health Services Administrative funding, that's called SAMHSA. Of course, the BHSA funds, all of our Medi-Cal, so that includes our specialty mental health services, and for the counties, either the drug Medi-Cal or the drug Medi-Cal organized delivery system, and then also any other behavioral health focused federal, state, or local funds. Next slide. And so I just want to talk a little minute here about the budget. And so these are some areas that we are considering including around the budget reporting structure. One, that the budget be disaggregated, but basically, set apart with mental health and substance use disorder. Also having that kind of same disaggregated approach by adults and children. And then also reporting each COC, which is, I'm going to get into that in just a moment, but it's basically that continuum of care of services, but having reporting done by those. So as an example of that, by harm reduction, by treatment, by recovery services, those type of categories, by housing, things like that. Next slide. So as we're developing out this template for the budget reporting structure, what key elements would you want DHCS to capture? So I mentioned a few on the slide previously of having that disaggregation between mental health and substance use, collecting it between adults and children and youth, and also collecting it across that continuum of care. Do you agree with those elements? Are there others that you would like us to capture? And with that, we're going to move over to the Q&A and start reading some of your feedback.
As we're waiting for the comments to come in, they seem to come in heavily after about the first minute. There's a question about if the prevention dollars have been moved over to CDPH, what prevention dollars would they be spending? So Marlise, if you could clarify that a little bit.
Sure. So there are other funding sources where prevention dollars are allowable. One of those is the SAMHSA funds that I was just mentioning, and that is with the substance abuse, which is actually now changed to the substance use block grants. So counties receive those allocations for every 2 years, and there is an actual prevention set aside for the use of those funds.
So we have some suggestions about differentiating between adults and older adults over 60. There's a suggestion to mimic the county budgeting process.
Also seeing a great comment in here about co-occurring. So how would that be captured? Making sure that that is captured.
There are also many suggestions about race, ethnicity, gender, including transitional aged youth or TAY. Supportive housing.
Also just seeing, making sure that whichever categories are utilized to make sure that it's not too split out, because sometimes then it's difficult to report, and then there can be overlap and duplication in that reporting.
There's a suggestion to not disaggregate by level of care. And there's also a suggestion to keep budgeting simple because it's a plan. It's not necessarily how a county is spending their funds.
Great. Also seeing a lot around just ensuring that whatever is reported in the integrated plan is then reported out in how counties expended the funding. So that would actually be a part of the voter, but making sure that there's that correlation there. Okay, I'm gonna move us to the next slide. So do want to talk a little bit, we've touched on this continuum for behavioral health. So just want to talk briefly about the framework for the continuum. Next slide. So as required in statute, the integrated plan has to include a demonstration of how the county will utilize the various funds that we've been talking about today for behavioral health services to deliver these across a continuum of services. And this is to be in the least restrictive setting. And then it has a listing here of some of the settings that should be included. Next slide. So with that, DHCS is working toward a behavioral health services and program reporting framework so that we can, once again, we're back to those apples to apples, but also that can allow for a gap analysis and one-to-one comparison of services under the different funding streams. I had mentioned, just as an example, around prevention funding that we have for our sub-G under SAMHSA funds, as well as we have that for our MAB-G as well, which are also federal funding that can be used for prevention activities for individuals for mental health services. But once again, really wanting to ensure that multiple funding sources can be allowable for treatment services. So how do we make sure that we have this one-to-one comparison? Unfortunately, there's not a straight path forward for all of the mental health and substance use disorder services. There's a lot that are very close and similar, but so we have been doing a lot of research and work into how do we categorize these. So once again, we're able to see this across the continuum, which is required by the statute. And so what our goal is to have some form of a behavioral health services framework that has mutually exclusive service categories, once again, so then they can be compared across the various funding sources. Next slide. So with that, there's been a few frameworks that have been developed. There's one framework that has been developed and it's described in the DHCS report for assessing the continuum of care for behavioral services, or basically our big needs assessment that we had done in California back in 2022. So a framework was created there. It includes 8 core service categories that make up a backbone of the behavioral health system. Next slide. So in that, just wanted to show you, what that framework looked like in 2022, recognizing from some of the comments that we've received, there's been a lot of changes even since 2022. So really on the right hand of the slide are just some of the areas that we would see that would need to be adjusted from that framework. Once again, we're not stating we're going to use this exact framework. This is just some initial thoughts that we've had to ensure that we have the entire continuum of care. You'll notice on the right some of the additions around housing services and supports. And then also I do want to draw your attention to the bottom 3 that are listed around peer support services, case management, care coordination, and family services and supports. Those are really cross-cutting across all of these different areas. So just wanted to highlight those as well. Next slide. So with this, what are some of your thoughts on utilizing this draft continuum of care framework for organizing the data? Or are there other changes you would recommend to this revised framework? Or are there other ideas that you have around how we can, create this framework for the continuum of care? And so, Emma, if you wouldn't mind once again, just popping back to that last slide. So folks can see some of our initial ideas around a revised continuum framework. So once again, just want to repeat the question. What are your thoughts around this revised framework? Are there categories that are missing here? Or are there other framework ideas that you have in mind that you think would be better than utilizing this one? So just want to open it back up for your comments in the Q&A.
So we've gotten a couple comments that there is a continuum of care that's related to homelessness, and asking if it's similar, this is specific to behavioral health delivery system. We've gotten a couple that say they think it's great. There are some suggestions about adding forensic services, both in custody and re-entry. Some suggestions to keep recovery services. So a comment about being clear on all the definitions, but especially early intervention.
So I want to jump in here about a comment of adding community defined and culturally relevant services, since those might not fit into some of these other categories. Also just want to call out kind of to your point, Tracy, of making sure these are defined. This individual brings up the housing category, really making sure that it's not just housing services and supports, but also the actual housing, the rental assistance, those type of services, or be sure it's defined.
There's another suggestion about including outreach and advocacy. And multiple comments, as you said, about clearly defined what is contained in each of these categories.
Great. Well, thank you so much for your feedback on this question. I do want to move us to the next slide. So that's just a huge thank you. I do just also want to point out, we have more information on our website, and we are continuing to add resources each week. There's currently a broad timeline that has recently been posted around DHCS's efforts, which is a little more expansive than the milestones I walked you through earlier. So I'd encourage you to check that out. And we'll be adding fact sheets, FAQs, and other information as well, and infographics as we continue this rollout together. We also have here listed on the screen our BHT mailbox. So I would encourage you, if you have further feedback from today, please use this. And as I mentioned, we will be putting a summary document together of what we've heard today from folks, and then any further comments that we receive. That doesn't mean that you can't continue to provide us feedback. Because I mentioned earlier, our goal is to have that county integrated plan template and that policy guidance out in early 2025. So we still have time. I really want to thank you for just allowing us to walk you through the statutory requirements and some of our initial thinking, and for making the time to provide your feedback, because that really is going to assist us as this gets further developed. So with that, just a reminder, we will be posting this PowerPoint as well as the recording and then the summary information. So thank you so much for making the time to spend with us today, and hope to see you next month for our next public listening session. Thank you and have a great day, and thank you for your service.